So exactly like Justin said, I'm going to be talking with you about the emerging immunotherapy treatment paradigms in GU oncology. And there have really been a lot of changes over the past couple of years. So this is an overview of my talk. It's a kind of busy slide, but basically I've divided my talk into the three major GU cancers that we see: kidney cancer, urothelial cancer, and prostate. And for each, I'll talk about some of the recently approved immunotherapy regimens, as well as in italics, some of the combinations and other sort of immunotherapy regimens ongoing in clinical investigation. Before diving into the specifics of the diseases, this is a slide I adapted from a GU ASCO talk 3 months ago by James Gully from the NCI. And this is another way of showing what Justin showed earlier in terms of tumor mutational burden across different human cancers. Here on the left, x-axis, somatic mutations per MB, and then here on the right, TMB here. On the paper on the right, they also looked at this T-cell inflamed gene expression profile. And here on the y-axis, this is sort of response to anti-PD-1 or PD-L1 therapy. So I've highlighted the GU cancers, the three major GU cancers in red. And you can see for urothelial cancer, it has a relatively high somatic mutational burden compared to other human cancer types, and it has a response rate to anti-PD-1 or PD-L1 therapy on the order of 15 to 20%. For kidney cancer, it's actually a little bit of an outlier. It's got a moderate tumor mutational burden, but has a higher propensity to respond to immunotherapies and PD-1 therapies. And here, it's a second-line study that they cited here with a response rate to nivolumab of 25%. But there's actually data to suggest that the first-line response may be as high as the high 30s or 40%. And then finally, for prostate cancer, you can see low tumor mutational burden and a response rate only on the order of 5 to 7%. On the right is a more recent paper where they looked at not only tumor mutational burden, but this T-cell inflamed gene expression profile. And I think some of this may explain why kidney cancer is an outlier. You can see here, over 90%, nearly all are categorized as having low tumor mutational burden by the stratification that they use in this paper. But about 70% actually had a high T-cell inflamed gene expression profile despite that. And there's data to suggest that kidney cancer actually has the highest proportion and number of insertion deletion mutations among human cancers, and potentially those are the ones that are truly the ones that elicit an immune response. For prostate cancer, you can see, unfortunately, the vast majority are low for both, and for bladder cancer, sort of a mix. I will point out that the immunotherapies really made headway into GU cancers very early on. So these, BCG has been used for non-muscle invasive bladder cancer for many decades. Interferons and interleukin-2, these cytokine therapies, have been used for kidney cancer, advanced kidney cancer, since the 80s and 90s. And then Sipuleucel-T, which is a dendritic cell-based therapy, approved for metastatic castration-resistant prostate cancer in 2010. So moving forth with the truly emerging immunotherapies in GU oncology, going into kidney cancer, this is CheckMate 214. This was published just over a year ago. I won't talk too much about the initial paper. I'll just kind of show this one slide about it, and then I'll talk about the updates that were recently provided. But this was published a year ago in the New England Journal. It was a randomized phase 3 study of first-line therapy where patients were randomized to receive nivolumab plus ipilimumab, and the doses here were 3 mg per kg for nivo and 1 mg per kg for ipi for 4 doses followed by nivolumab. And the patients the comparator arm was Sunitinib, which has been the standard of care first-line therapy for advanced RCC for over a decade. The primary endpoints here included overall survival, progression-free survival, and response rates in the intermediate and poor risk patients, and that's sort of a stratification criteria that we have in advanced RCC based on a number of clinical factors. But this is basically, it's typically about 75% of all patients. You can see here on the left, the overall survival endpoint was reached with a hazard ratio of death of 0.63 and a p-value of less than 0.001 favoring Nivo plus Ipi. And then in terms of response rates in the intermediate and poor risk patients, 42% for Nivo plus Ipi versus 27% for Sutent. And I think equally as important is really this pretty impressive 9% complete response rate to nivolumab plus ipilimumab compared to 1% for Sutent. So the FDA, based on that data, approved Nivo plus Ipi in combination for intermediate or poor risk advanced renal cell carcinoma patients just a little over a year ago. The one hiccup in that original report was in the subset of favorable risk patients, 250 patients or close to it. And you can see here that the data, overall survival, progression-free survival, and response rates, it didn't seem that nivolumab and ipilimumab benefited these patients more so than Sutent. And if anything, the data might have suggested that patients with Sunitinib did a little bit better than those who received nivolumab and ipilimumab. Although, the caveat is this is a subgroup, exploratory analysis. The response rates, 29% for Nivo plus Ipi, 52% for Sunitinib, although the complete response rates for Nivo plus Ipi was still quite high at 11%. So this is the update from GU ASCO presented by Nazar Tanir from MD Anderson 3 months ago. This was a 30-month follow-up to CheckMate 214. And the takeaway is that in the intermediate and poor risk patients, the data held up. The benefits to Nivo plus Ipi over Sunitinib was still present and didn't change very much at all. But in those patients with favorable risk disease, the differences between Nivo plus Ipi versus Sunitinib had closed. So you can see here the overall survival hazard ratio now 1.22, which is lower than what it was reported before. Curves were closing. And in the favorable risk patients, the median PFS, previously the hazard ratio was 2.18, I believe, and the p-value that was less than 0.001. Now the gaps were closing. And furthermore, in terms of response rates, here in the favorable risk patients, response rate up to 39% for Nivo plus Ipi versus 50% for Sunitinib. In terms of the overall population, you can see here at 30 months follow-up, 10.5% of patients, of all patients, had a complete response to Nivo plus Ipi. So that's pretty impressive. So this was a treatment landscape for metastatic RCC as of really 3 weeks ago. And since then, over the past 3-4 weeks, 2 additional regimens were approved. These were 2 studies among a set of 5 studies with similar themes of combining anti-angiogenic therapies plus either anti-PD-1 or PD-L1 therapy. The 2 in yellow have reached FDA approval, and the one in bold had hit an overall survival endpoint. So the rationale for combining these therapies were twofold. One, anti-angiogenic therapies alone work for metastatic RCC, and immunotherapies are efficacious for advanced RCC. But there's also a whole host of preclinical data, and I see Rakesh Jain will be giving a talk later today. There's a whole host of preclinical data to suggest that VEGF signaling leads to an immunosuppressive tumor microenvironment by sort of a number of downstream effects that result in an increase in myeloid-derived suppressor cells, increases in regulatory T cells, decreases in antigen-presenting cells, and decreases in effector T cells. There's also data to suggest that anti-angiogenic therapies may lead to vascular normalization and converting an immunosuppressive tumor microenvironment to an immunosupportive one. So these are 4 phase 1 studies of those anti-angiogenic therapies plus anti-PD-1 or PD-L1 therapies. And you can see very high response rates ranging from 54% in the second-line setting to up here 73% in the first-line setting for Axi plus Pembro. And all 4 of these were carried forth into phase 3 trials. So I'll spend a little bit of time talking about KEYNOTE-426, which was a randomized phase 3 trial comparing Pembrolizumab plus Axitinib versus Sunitinib for advanced RCC. And this is the baseline demographics, pretty well balanced. It's pretty standard patient population for first-line clear cell RCC. You can see that about 30% of patients had favorable risk disease, which was something that people were paying attention to based on the prior Nivo plus Ipi data. The overall survival endpoint was one of the co-primary endpoints, and you can see here hazard ratio for death of 0.53, p-value of less than 0.0001, favoring Pembro plus Axi, with the curves starting to splay out quite early on. They looked at a number of different subgroups, and all subgroups seem to benefit more from Pembro plus Axi versus Sunitinib, including those with favorable risk disease here, and including those with high or low PD-L1 positivity. And I won't talk too much about PD-L1 positivity here in really any of my diseases, but part of the reason is that it really hasn't been shown to be a great biomarker in kidney or bladder cancer. There's some skew towards more likelihood of response, but it's not a great marker overall. In terms of response rates, nearly 60% of patients responded to Pembro plus Axi versus 36% for Sunitinib, and complete response rates 5.8% versus 1.9%, and the median duration of response was quite long. And I think one question that will be interesting, and we'll see how it plays out in the upcoming years, is how much of this is additive, because we know that these therapies individually are active in kidney cancer, and how much of this may be synergistic. So here's some data from first-line therapy of Axi plus Pembro, just in terms of response rates, 32% for Axi alone. Pembrolizumab, a phase 2 data, 36%. In terms of toxicity, so one concern was when we're adding these two therapies, are we going to see a ton of toxicities? And we do see a lot of toxicities. These VEGF receptor-targeted TKIs aren't the easiest to tolerate. Grade 3 or higher adverse events were 71% in the Sunitinib-only arm, but it wasn't that much higher in the combination arm, 76%. A lot of patients did discontinue therapy due to AEs. Over 3 in 10 discontinue one drug or other in the combination arm, and 11% discontinue both drugs. The FDA, based on this data, approved Pembrolizumab plus Axitinib for advanced RCC just less than a month ago, and that was for all IMDC risk categories, including the favorable risk patients. And then one slide about this study, JAVELIN Renal 101, which had a very similar design to the KEYNOTE-426 study that I just talked about. In this case, they use an anti-PD-L1 therapy, avelumab, plus the same VEGF receptor-targeted TKI backbone, Axitinib, versus Sunitinib. In this study, the primary endpoints were actually PFS in the PD-L1 positive patients and OS, overall survival, in the PD-L1 positive patients. By PFS, there was a benefit, statistically significant benefit to avelumab plus Axitinib. In terms of response rates, you can see the numbers up here. Slightly higher in the PD-L1 positive patients for the combination. But this study has not yet reached an overall survival endpoint. So this was in the supplementary figures. The hazard ratio was 0.78, did cross 1, p-value of 0.14. The curves split a little bit, but have been running together since then. So I think longer-term follow-up will definitely be needed to see if this ultimately hits an overall survival endpoint. But nonetheless, the FDA just earlier this week approved avelumab plus Axitinib as frontline therapy for advanced RCC with the same label in terms of all IMDC risk categories. And I will also show a slide doing cross-trial comparisons. So these are the three major randomized phase 3 trials over the past year or so. and the comparator in all 3 studies was Sunitinib. And you can see there's a lot of nuance. I think at this point, Pembro plus Axi and Nivo plus Ipilimumab have individually shown very strong data in terms of hitting overall survival endpoints. Hazard ratios are slightly different, but are they all that different for the intermediate and poor risk patients? It's hard to say. In terms of response rates, you can see here, it does seem like the VEGF plus IO combinations tend to have a higher response rate. But on the other hand, this 10.5% chance of a complete response for nivolumab plus ipilimumab is pretty enticing, nearly double what it was reported for the other studies. There's, treatment-related AEs. There's a lot of nuance to that. Grade 3 adverse events in terms of the proportion of patients who develop that, much higher for, the TKI plus IO combinations than what it was for Nivo plus Ipi. But the treatment-related deaths and, obviously immune-related toxicities were higher for the nivolumab plus ipilimumab arm. So this is the current systemic treatment algorithm. I think, at least in my view, so for favorable risk patients, to me, Axitinib plus Pembrolizumab has now become the standard first-line therapy in that space based on hitting that overall survival endpoint. In terms of intermediate or poor risk patients, both regimens, Nivo plus Ipi or Axi plus Pembro, are reasonable, and they have different considerations, like I mentioned. And I think you look at the patient, and if it's somebody who I'd want to have a higher likelihood of response, if again, going back to what Justin talked about, similar to what Justin talked about earlier in terms of having one shot on goal, potentially, then I would probably pick the Axitinib plus Pembrolizumab arm. On the other hand, if I have some time and the patient understands that there's sort of these trade-offs, the 10 to 11% complete response rate for nivolumab plus ipilimumab is very enticing. And then for second-line therapy and beyond, really it's a data-free zone. We don't know. These therapies are so new. Fortunately for renal cell carcinoma, we do have a lot of different therapies and a lot of different options, but in terms of the best option after these first-line therapies, it's really unclear. There are additional ongoing phase 3 trials, so I'm going to move on into sort of what's next. So 2 additional studies that one has reached accrual goal, and I think one is close. We're looking at other combinations of PD-1 or PD-L1 therapy, or I guess in this case PD-1 therapy plus different TKIs, and they'll likely read out over the next year. So I've shown you a lot of data on combinations of PD-1 or PD-L1 plus either CTLA-4 therapy or TKI. What about just anti-PD-1 therapy alone, given the 46% to 76% grade 3 or higher adverse events with all those other combinations? So this was looked at and presented a year ago at ASCO, a phase 2 study looking at Pembrolizumab monotherapy. And it actually showed in this 110 patients a fairly high response rate, 38%. Complete response rates were lower than what was reported in the other studies, 2.7%. But on the other hand, it was much better tolerated. So certainly something to be considered. So how do we build on the IO successes in frontline metastatic RCC? So one option is further treatment escalation. So this study was announced a couple of weeks ago. It's Cosmic 313. It'll be a randomized phase 3 study of intermediate and poor risk patients with advanced RCC. And patients would receive either nivolumab plus ipilimumab plus cabozantinib, a VEGF TKI, versus Nivo plus Ipi plus placebo. And this will be the first study that will look at the question of IO plus TKI versus IO. And then, given all the toxicity questions and the data that I showed earlier with Pembrolizumab monotherapy, the other option is looking at treatment modulation and de-escalation. There's, certainly some patients seem to do great and can avoid the toxicities with just PD-1 monotherapy. And there are 2 very similarly designed phase 2 studies where patients start with nivolumab, If they have a complete response or partial response, they continue with nivolumab monotherapy. If at any point they have progressive disease or stable disease, sort of less than optimal response, then ipilimumab would be added. So those are ongoing as well. And then how can we extend the IO successes to localized high-risk RCC? So currently, for stage 3 renal cell carcinoma, the likelihood of metastatic recurrence is about 50%. And there's one FDA-approved drug in that space, which is Sunitinib adjuvant. However, it did not show an overall survival difference and only showed a disease-free survival benefit. And so it's not clear who should be getting that drug and who shouldn't, given the toxicities I just talked about with Sunitinib. There are 5 phase 3 trials in this space of high-risk stage 3 RCC. The one on the left is perioperative. Patients get nivolumab, followed by nephrectomy, followed by 9 months of nivolumab, or they may be randomized to receive nephrectomy followed by observation only, which is a standard of care option. On the right are 4 additional phase 3 trials truly in the adjuvant space, so after nephrectomy, and looking at various IO regimens versus either placebo or observation. So I spent most of the time on RCC because I think that's where most of the changes have occurred over the past year in GU cancers as far as immunotherapies go. We'll move on to urothelial cancer. There have been a lot of developments over the past 3 years or so in urothelial cancer. So this study, a phase 2 study on atezolizumab for platinum refractory patients with advanced urothelial cancer, was published 3 years ago and led to FDA approval, accelerated approval, because traditionally urothelial cancer post-platinum, there's really not many options. The traditional therapies are these single-agent chemotherapies that have response rates on the order of 10-15%. Since then, pembrolizumab, avelumab, nivolumab, durvalumab have been approved in the second-line setting. Pembro in the first-line setting for cisplatin-ineligible patients, atezo in the same first-line indication. So really 5 second-line approvals and 2 first-line approvals over the course of 1 year. This is a summary slide showing the kind of major data points from second-line studies. And you can see here, pembrolizumab in phase 3 actually is the only one that has shown an overall survival benefit on a randomized phase 3 trial. Response rates ranging from 13 to 21%. So this is while this is a big improvement for our patients, there's a lot to be desired. The pembrolizumab data I'll show briefly, but it's a couple years ago now. There was an overall survival endpoint that was reached, has a ratio of 0.73 over chemotherapy, which was investigator choice taxanes or vinflunine. Response rates 21% versus 11% in the total population. Not too different in this high PD-L1 combined positivity score population, 21% versus 7%, so lower for the chemotherapy, but in terms of the pembro response, it's not too different. However, complete response rates were higher, median duration of response was higher for immunotherapy, and furthermore, toxicities were much less with pembrolizumab, 15% for grade 3 or higher versus nearly 50% for chemo. In the first-line setting, this is just a summary slide of the 2 phase 2 studies, single-arm studies that led to approval of atezo and pembro for first-line therapy for cisplatin-ineligible patients with advanced urothelial cancer. Response rates 23-24%. One update over the last summer, was that the FDA had reviewed preliminary data from 2 ongoing phase 3 studies involving these 2 regimens in the first-line setting. And what they found was that for patients who were eligible for platinum-based chemotherapy, if they had a low PD-L1 positivity score, they seemed to do a lot worse, at least up to that point in the prelim analysis. They did a lot worse with atezo or Keytruda, pembrolizumab, versus chemotherapy. So they restricted the label for frontline use of atezolizumab and Keytruda and pembrolizumab to those who either had a high PD-L1 expression score, and there were different scores, different cutoffs actually for the two regimens, or if they weren't eligible for any platinum-based chemotherapy. There's a lot of work in this space, a lot of ongoing work. So this is ongoing phase 3 immunotherapy combination trials in metastatic urothelial cancers. None of these have really reported any preliminary data up to this point. They will start to read out over the next year or two, all with similar themes, 3-arm studies where the comparator is the traditional standard of care, which is platinum-based chemotherapy, platinum cis or carboplatin with gemcitabine. And there are various combinations of immunotherapies, whether it's PD-1 or PD-L1 alone, PD-1 plus or PD-L1 plus CTLA-4 directed therapy, or immunochemotherapy. And so stay tuned. And then moving to earlier disease settings, so for muscle-invasive bladder cancer, this was a phase 2 study that was just published maybe 6 months ago now, where patients who were with muscle-invasive bladder cancer, where the standard of care traditionally has been cisplatin-based neoadjuvant chemotherapy, followed by cystectomy, patients instead could receive pembrolizumab 3 doses, followed by cystectomy. There was this, for sort of non-responding patients, they would end up getting the chemotherapy, but for the most part, very few patients ended up getting that. And pretty impressively, they showed a pathologic complete response rate, meaning no residual tumor in 42% of these 50 patients. And in those with a high PD-L1 score, it was up to 54%. They did try to look at some biomarkers, sort of pharmacodynamic data that did show that these drugs obviously were doing something to the tumor at resection. And then this was a very similarly designed study, ABACUS phase 2 study, neoadjuvant atezolizumab now for muscle-invasive bladder cancer. In this case, they only actually got 2 doses instead of the 3 for pembrolizumab. And they showed path CR rates of 29% for all comers, 40% for those who were PD-L1 positive. Even for those with with deeper levels of tumor invasion, T3 or T4 disease, there was a 15% pathologic complete response rate. And similarly, they showed some pharmacodynamic data suggesting increases in PD-L1 positivity at time of surgery and increases in CD8 positive T cells. So those are also being carried forth into phase 3 studies in muscle-invasive bladder cancers. So a number of different studies with 2 additional that will be opening up in the next month. And they have slightly different themes. Patients may or may not have received the standard neoadjuvant chemotherapy, and even if they did, they can go on to get immunotherapy or observation or placebo in some cases. And if they didn't get chemotherapy, there's different criteria for enrollment, but really kind of variations on the same theme. Chemoradiation therapy, Trimodality therapy, is a standard of care for some patients with muscle-invasive bladder cancer. And this is a SWOG NRG study where patients will be randomized to receive either chemoradiation or chemoradiation plus atezolizumab for 9 doses. And that will be opening up at our center soon as well. And finally, it's really, immunotherapies are really permeating into really every part of urothelial cancer, so even in non-muscle invasive bladder cancer. For those with high-risk disease that are unresponsive to BCG, which is a standard therapy for non-muscle invasive bladder cancer, this was a phase 2 study presented a couple of months ago where patients would receive 2 years of pembrolizumab IV, and they showed a pathologic complete response rate, at 3 months of 40%. And none of the patients had progressed to muscle invasive disease or metastatic disease. And again, that building on that, phase 3 trials that have recently started looking at immunotherapy even in the non-muscle invasive bladder cancer space. So I think for bladder cancer, a lot of developments over the prior 3 years, and hopefully a lot more to come in the near future. And then finally, I'll spend a few minutes talking about prostate cancer. Unfortunately, immunotherapies haven't made much inroad into prostate cancer. It's not for lack of trying. So ipilimumab was looked at very early on in metastatic castration-resistant prostate cancer. This paper from 2014. So this was in the post-chemotherapy space. Patients were randomized to placebo. Here on the right, pre-chemotherapy patients randomized to ipilimumab at, in these cases, 10 mg per kg versus placebo, 10 mg per kg for 4 doses. And you can see here, no survival benefit compared to placebo. And PSA response rates were quite low. What about PD-1, PD-L1? So pembrolizumab in the post-chemotherapy space presented last year a response rate of 4.5% by RECIST, and PSA response rates only 16%. What about combinations? Nivo plus Ipi. This was presented 3 months ago at GU ASCO. So small numbers of patients overall, pre-chemo here, post-chemo here, response rates 10 to 25%. They looked at a number of, sort of factors to try to, the usual suspects to try to see if we can, figure out what biomarkers may be helpful. It's really hard. Nothing really jumped out. It's really hard to tell, especially with these small numbers of responders overall. But again, not for lack of trying. And then combinations with PARP inhibitors, which are starting to make inroads into prostate cancer for patients with homologous recombination defects. In this case, this study was a phase 2 study where none of the patients actually had any homologous recombination defects. They showed a 7% response rate with the combination of olaparib plus pembrolizumab. I think the only place where it's had some efficacy is in prostate cancer with MSI high status or mismatch repair protein deficiency. So Justin mentioned the approval for pembrolizumab earlier in that space. This was a paper from recently from Sloan Kettering, where they went back and looked at all of their tumors, 1,000 tumors with prostate cancer, and found a 3.1% chance of detecting MSI high or MMR deficient tumors. And these are obviously the tumors with high tumor mutational burden. And of those 32 patients, 11 underwent PD-1 or PD-L1 therapy. They went back and retrospectively looked at it. And of those, 6 or 54% had a PSA decline of greater than 50%. And 4 of those with radiographically evaluable disease had an objective response. So certainly for a minority of patients, a subset of patients, immunotherapies do seem to have activity and benefit. So here's a long table of phase 3 and phase 2 trials that are ongoing in the metastatic castration-resistant prostate cancer space. Variations of different combinations building on a PD-1 or PD-L1 backbone. And you can see here with enzalutamide, PARP inhibitors, chemotherapy, other PARP inhibitors, CTLA-4, radium therapy, and bipolar androgen therapy. And so we'll see, whether any of these can make headway. And then, some early data on phase 2 studies in this space as well, looking at either biochemically recurrent prostate cancer or localized disease, either low-risk disease in this case or high-risk disease. So this is a summary of what I covered. It's a lot of information, but I think it's an exciting time in GU oncology, and certainly for kidney and bladder and kidney and urothelial cancers, we've made a lot of headway, and for prostate cancer, we'll see if hopefully some of these combinations would boost response. Okay, I'll take any questions.
We've got the microphone here. So any questions about urothelial malignancies and immunotherapies? So I'm going to kick off then, and not probably the best person to ask questions here, but so, I mean, actually in some ways you guys have been the pioneers with the BCG therapies of bladder cancers. What do you think why hasn't it been working quite as well in the prostate cancer as it has with the renal cell cancer, for instance?
I think obviously, it's a difficult question. By what one of the first slides that I showed earlier, very low tumor mutational burden, doesn't a cancer type that doesn't seem to elicit much of a T cell response, at least in normal settings. There are these, minority of patients or minority of cancers within prostate cancer that does seem to be an outlier. But for the most part, these are pretty cold tumors, and we look to folks like you to see if we can flip the switch.
We're trying. Yeah.